Okay, let's go ahead and get started. Good afternoon. Welcome to Medical Grand Rounds. It's a pleasure for me to introduce Jeff Wallace to you today. Jeff is one of my favorite faculty members in the Department of Medicine because he takes care of my mother. What's that? Oh, you are? No, it's not a HIPAA problem. She gave me permission for this. So Jeff is also a professor of medicine in the geriatrics division, and he's the director of clinical geriatrics. Jeff received his undergraduate and his MD degree from the University of Michigan, and he graduated from the School of Medicine, Alpha Omega Alpha. He then went on to do his house staff training here and became medical chief resident here as well, and then went to the University of Washington for a fellowship in geriatrics. He also received an MPH at the School of Public Health at the University of Washington. Jeff has been successful in pulling together a number of foundation grants that focus on health in the elderly and trying to make the elderly as functional as possible. And he's done that in terms of his research, and I can attest that he's done that in terms of his clinical care as well. He's an outstanding clinician. He focuses on frailty and drug-drug interactions, and he's going to be talking with us today about some clinical pearls in geriatrics. So please join me in welcoming Jeff Wallace.
Thank you very much, Dr. Schwartz. And thanks. Good to be here with you. For the next 45 minutes or so, I'll go through a hodgepodge of geriatric topics that I think will hopefully be pertinent to your practice in the hospital and in the clinics. So I'm going to start in with a couple of nutritional issues, talk about prescribing in the elderly or hopefully de-prescribing, and then finish up with some ideas about cancer screening and care in advanced stages of dementia. So I'll start right in, and so I'm fairly technophobic, but for those who are savvy, and it shows on the screen here, we're going to have voting for 5 different questions along the way. And if you go to respond.cc, for anyone who's able to get to respond.cc website, there will be a link there to put in and vote with a key session key for each question. So hopefully, if people know how to do that, if not, we'll just kind of raise our hands or vote internally. I'll go through the case scenario. So we have a 78-year-old woman who has diabetes, hypertension, GERD, and osteoarthritis and depression. She comes in, there's a routine clinic follow-up. She's complaining of her knee pain and her mood. And says she's not so sure that her sertraline's doing all it should. Her other meds are pretty much as expected for her blood pressure and her diabetes. Looking at her med list, the metformin, lisinopril, omeprazole, sertraline, and Tylenol, being the astute clinician you are, you wonder about, she's at risk for a relevant, possibly relevant for her symptoms today, micronutrient deficiency. So on your list of things that you should be ordering, if you're able to vote, would you order a vitamin B12 level, a vitamin D level, a magnesium, or a calcium level? And 2 drugs, there's some that you could argue one of the drugs could affect a couple things, but I'll see if this is working. We'll flick to the next slide and see what happens. At least some are savvy in accessing. And the correct answer in our population here is correct. Vitamin B12 is what you should know about. And so I'm going to spend a moment or two just talking because it's both the metformin and the PPI. And as it turns out, B12 levels, when they're low, are more associated with neuropsychiatric problems, including depression. It's not like a patient who has Alzheimer's dementia, comes in happily impaired, is B12 deficient. We always get B12 levels, and they're very frequently low, but they present differently than kind of a standard Alzheimer's patient. And when you have patients who have mood problems, particularly at old age, new onset, you should be checking vitamin B12 levels because prevalence rates of depression are about 2-fold increased in patients with low B12 of getting depressed. So everyone knows to check a TSH. I haven't had a patient with depression who doesn't have a handful of TSHs, but a lot of them don't have the B12. This patient in particular needs it because of the metformin and the PPI. So across the board, B12 deficiency is about a 10%er if you just check it in all your older adults. But it will be up possibly twice as high in patients who are on metformin. The mechanism is a decreased absorption. Your liver stores about 4 years of metformin, of the B12, so it takes continuing ongoing metformin to not absorb over time and use up your stores. But you will ultimately have an increased likelihood of getting B12 deficient. This was shown in the diabetes prevention trial, which is a study that included a metformin arm to try and prevent the onset of diabetes in patients with impaired glucose tolerance. They gave them 850 of metformin twice a day, followed them for 5 and some out to 10 plus years. And what they found was for people with really low levels, below 200, they had about a twofold increase if you were in the metformin group. And having modestly low, but as we'll see in a minute, levels that probably are treatable, they had about a 20% rate for the folks on metformin, about double for the people on placebo. So it's something we should think of. We're using more and more metformin. We're going to see it in a lot of patients, and God knows we have more and more patients on PPIs, even though we're trying to get them off. So this patient has the double whammy, which is going to be pretty common. The mechanism for the PPI effect is also a decreased absorption. So when you eat food, most people, unless they're a strict vegetarian, get plenty of B12 in their diet. You need 2 micrograms. Most people have 6 to 9. The problem is it comes bound to protein, a steak, an egg, whatever you're eating that's got the cobalamin. And if you don't have stomach acid, you can't get the food and the cobalamin, the protein, apart to get the R protein on. And then when it hits the jejunum, you can't get it off because the trypsinogen and pepsinogen is not activated because you don't have stomach acid. And you basically don't absorb B12. Kind of a similar process as the metformin issue. There was a study in JAMA, this is almost 5 years ago now. PPIs really did increase the risk, and this was a Kaiser, several tens of thousands of patients who were taking PPIs for 2 or more years. They had a 50% increased risk of having B12 deficiency. If they were on higher dose, 2-dose BID PPIs, the risk was almost twofold increase. Now, you're not completely off the hook with ranitidine, your H2 receptor antagonist, but it's a much lower effect, and I don't worry too much about it. And, sooner or later, your patients with GERD often need some acid suppression. I think we all know, just a quick tangent, we try and get our patients off PPIs. There's good studies on PPI discontinuation that 2 out of 3 patients will end up taking their PPIs chronically. But for non-erosive esophagitis, this is one more reason to try and get your patients off the chronic PPI or to a lower dose. And they will have rebound. If you just tell your patient, I don't want you on that PPI anymore, stop it, you better warn them. Their gastrin levels are up. They may get rebound hyperacidity. You need to tell them if they're at twice a day, go to once a day. If they're once a day, can you lower the dose? You'll less likely have problems with kind of this rebound worsening of symptoms. And then I have the litany of lists of things that we otherwise don't like chronic PPIs for. Yes, it throws off B12, but also magnesium, calcium, iron. It actually can decrease your levothyroxine for patients who are getting synthroid replacement therapy, and definitely increases C. diff recurrences. If you have C. diff and you're on a PPI, we try and get the patient off the PPI. The CKD association is probably real, so is the fractures. The mechanisms aren't exactly clear, but the dementia, I don't know about you, my mother called me on the way home from work last year saying, you've let me be on my omeprazole for the last 10 years. It's causing dementia. It was on NPR, and there was one retrospective study, which is not very compelling, that showed an association between chronic PPIs and dementia. There's a theoretical mechanism. It affects your amyloid processing in your brain. I don't think it's cause and effect, but it sure made a lot of my patients be more happy to come off their PPI and try the H2 block, even though it's not really a big concern to me. So a couple closing points on the B12. So my argument, and Sally Stadler here at the U wrote the NEJM review 4 years ago, saying you should be checking your B12 level in all 65-plus-year-olds. And the question is, well, how often? Because, frankly, if we did one study together, and we checked people who hadn't been checked in 5 years, and the prevalence rates were the same, 10 to 15%. And if you wait for symptoms, I mean, I don't know about you, but my whole clinic has people with a little weakness, a little dizziness, a little balance problems, a little forgetfulness. I mentioned the mood problems. And if you're waiting for an MCV to come up, you often won't see that in the older patients because there's folate in the food fortification system, and they often have mixed anemias. So the MCV isn't a signal either. So you need to check the level, is my argument, especially for patients on these at-risk drugs. The problem is the assay's lousy. So in the 150 to 350 range, you can't really rule out B12 deficiency. The lower you go, the more likely you're low. The higher you go, until you're at 350, there's actually a 90% rule out at about 350. So if you're above 350, you're probably replete. If the neurologists use 400, because they're looking at anything that they can treat, they want about a 99% rule out. So B12 above 400 would be a sufficient level for them to say we think it's a good rule out. Now, if you're a purist, you're going to get an MMA level. A methylmalonic acid level will tell you what's going on at the cellular level, and you don't have to worry about the B12 level. I actually used to be a very expensive assay. I just rechecked it. It's $50. So if you're a purist, say, I don't know, the B12 level's 250, I'm not going to treat the patient. I'm going to find out if they're really deficient. At the tissue level, we'll get an MMA. The problem I have with that, it's renally cleared. Half of our patients have CKD. The MMA is high. It would be a false positive. But if it's borderline, do I check it again? I just get on with therapy. And so therapy, and I think that's the best approach, and I think that's what neurology does. Anyone who's below 350, certainly below 300, just treat them. And I'm shameless. I sell any placebo effect I can. I know why you're tired, weak, and dizzy and wobbly. You're going to feel so much better. And go on with the drug. And the drug, turns out, you don't need to give them shots. So the shots are IM shots. They're not particularly comfortable, and they're once a month. Head-to-head studies, again, a lot of the work's done by Sally and reviewed in her NEJM review. 1,000 micrograms once a day. That's a super, super physiologic dose. The RDA is 2, so it's 500 times the RDA. And if you take 1,000 micrograms, even if you don't have a stomach, you have no stomach acid, you have no intrinsic factor, I cut out geranium. If you have a small intestine, by diffusion, 1% will get through in the jejunum to duodenum area, and you'll get 1% of 1,000 is 10 micrograms, 5 times the RDA. It works. So only in non-compliant patients and patients who have severe disease, initially you probably want to get them going with injections, but you can switch to oral. I have some patients who like the injections. And I don't know if it's placebo effect, but I'm happy if they want to get the shot, but they don't really need it. I'm going to move on to the next nutritional topic. Common situation in the hospital. 75-year-old woman falls down, suffers a hip fracture. Post-operatively, her crit drops somewhat substantially, so her hemoglobin is down to 8 from 12. She's got cardiovascular risk factors of hypertension and diabetes, but no known cardiovascular disease. She says she's doing fine. She's working with therapy, maybe a little tired. And the question is, and tell you what happens when I get these patients from the orthopedic service at my nursing homes or over to the ACE unit, they get iron. And the question would be, what would you do with this patient? Would you give her once a day iron? Does she need twice a day iron because she's kind of low with cardiovascular risk factors? Should she get a different other than ferrous sulfate product, ferrous gluconate product, or is she getting in the range where you want to transfuse her? So we'll see if we can, as we get more facile with the technology, maybe we'll get more votes as we go. Okay, great. So you have to figure there's good test takers, because why would I bring up ferrous gluconate? So I've changed my practice in this. It actually turns out that, first off, the background, it's hard to absorb iron. We don't have a good way to get rid of iron, and our body's only way to get rid of iron is sloughing in the GI system, and we get rid of 1 or 2 milligrams a day. We tightly regulate absorption of iron. When we eat food, we get about 10% of it, and if you get a fair hit of iron, your system turns off and kind of counter-regulates and down-regulates iron absorption. And the RDA for a man is 10, and because you absorb very little of it. And for women, premenopausally, it'd be about double that. When we're giving the ferrous sulfate, it's got 65 elemental. And it turns out that's just way more than your gut can handle. And giving less elemental does the same job, as we'll see in a second, but on the other hand, gives you way less side effects. So I get these patients sent to me on 2 and 3 days, times a day iron. The other thing you should know is going from once a day. If I give you a single dose of any iron tablet, you've now absorbed 75% of what you possibly can absorb for that day. So giving it twice a day or 3 times a day, the marginal gain is minuscule, but the side effects are substantial as you go to twice or 3 times a day. So you should never dose it more than once a day. A quick comment on the blood transfusions. There's actually new guidelines out from the American Association Blood Bank. Hemoglobin's generally 7 for the level of threshold for transfusing unless you have active cardiac disease. However, there's a group, and this patient's in that group, who the 8 should be your threshold. So they've kind of compared 8 versus 10. Should I transfuse these people? And it turns out if you have an orthopedic surgery, a cardiac surgery, or you have known cardiac disease, you should start raising your eyebrows about giving the patient a pint of blood when they get below 8. So this patient was right at 8, but she doesn't have cardiac disease. Her surgery's behind her. So we didn't transfuse her. She came to me from the orthopedic service on BID iron. So the quick data is there's studies done on this, and they've been out there for many years. And it was just recently reviewed, though, by Dan Rocknews, a really good GI doc, saying we've been overdoing the iron. One study that was quoted was this one, 100 or so patients who are iron deficient. They're all in their 80s. And they were tested to give the RDA, basically 15 milligrams, versus ferrous sulfate, which will have, ferrous gluconate, but we're having close to the ferrous sulfate elemental iron of 50, or giving that 3 times a day. And what happened to their hemoglobin, what happened to their ferritin? And the bottom line is everyone's iron values and H came up about the same. What differed, and I show it in illustration form, so it's a little higher if you took TID, 50 milligrams, but not much. And the hemoglobin, everyone came up about 1 to 2 points after about 30 to 60 days in a similar fashion. The problem is, if you give the higher dose, the GI symptoms double, if not quadruple, as you go from the low dose to the medium dose to the high dose. And we have a lot of older patients who, post-hip fracture, they're not eating, they're not hungry, they're trying to rehab, and it can be a problem. And besides which, you don't want the phone call with the black stool saying, "Doctor, am I bleeding?" So I look at this and say, you're getting nothing beneficial, you're only getting harmful effects. And as an aside, a lot of patients just don't stay on the stuff. If you're going to replete iron after you've had blood loss, you need a couple, 2-3 months of iron repletion. And even if you pick a low dose, patients aren't always compliant. Half the time they had a GI bleed and are on a PPI. But we know PPIs make it hard to absorb the iron, which is already hard to absorb. You can give them with vitamin C or with orange juice. It helps a little bit, but not a lot. I become fond of IV iron, and I'm using it a lot more. And it turns out it's easier to do outside the hospital than inside. If you do it inside the hospital, we use Venofer iron sucrose. And that's a 200 milligram that you have to give IV once a day, and that's the max 5 days in a row to get the full 1,000 repletion. But you can give this new product, Injectafer or Farinject are the brand names, but it's a different sugar of iron that's got 750 milligrams, and they're in and out of the infusion center in 15 minutes. I mean, as long as it takes longer to get the IV hooked up. They run it in. It's rare, if unheard of, to have the anaphylactic reactions that people worry about. You can give it one time and you're done. If you really need to replete the heck out of them, you can give it twice, so once a week later. So I think, rather than fight with my patients, I'm giving them low-dose iron. If they're having any problems or it's early, this patient like this, frankly, probably could have got the IV iron. I'm not quite sure why the inpatient service isn't moving up to the new product and still using the Venofer, but that's what we're stuck with now. So I'm going to take a step back and say there's a few things that drive me nuts as a geriatrician. So I attended on the ACE just a couple of weeks ago, and there's always stuff, and it's funny because when you're in clinic, you tend to see these things. In the hospital, you tend to not always catch up with, the minor things that let the outpatient doc do it, but we never quite get to it. So just a few rants, 3 drugs. Muscle relaxants shouldn't be used. Anyone over 75, probably over 65. They just don't work, and that said, if anyone looked, the annals a couple months ago had acute back pain management, included muscle relaxants. Drove me a little crazy as one of the options. Those studies showed marginal benefit, substantial side effects. Sedation, frankly, anyone who feels better with the muscle relaxants because we knocked them out. It's not because their back pain was really better. They just slept through it. It's anticholinergic, orthostasis, falls. There's problems with especially all the old school muscle relaxants. And the animal studies that said it had some efficacy was borderline, and it was in 50 and 60-year-olds. So not 70, 80, 90-year-olds. Our emergency room doesn't give muscle relaxants for the most part to anybody who comes in with acute back pain. Second rant, Megace. Megestrol acetate. For patients who are dwindling, not eating, losing weight, you have 3 M's. You have mirtazapine if they're depressed. You have marijuana because it's Colorado. But you have medicinal marijuana as in Marinol or the other version. Or you have Megace. And I still see Megace used, even though it's been on the Beers list for some time of drugs you shouldn't use. It doesn't work. The studies show minimal weight gain. It takes weeks to months if it's going to work. It's a progestational agent, so it has increased thromboembolic risks, and there's a signal of increased mortality. So you're not doing anyone really any good. I still see it occasionally used. My other quickie, which I see a lot, and if you have a patient who's a stable CAD patient, they've had an MI 10 years ago, they're taking a baby aspirin. They come into the hospital because they have a new AFib or a new DVT-PE, and they have a reason to go on anticoagulation. And for the most part, as an aside, you're going to use warfarin or a 10A inhibitor. No one should use dabigatran or Pradaxa in older adults, period, ever. And we'll talk about that if you want a question and answer. So these patients will get a 10A or warfarin for the most part for the new indication for anticoagulation. They do not need their aspirin. Their aspirin should stop. If you don't stop their aspirin, you will have a 2 to 3-fold increased bleeding risk, but you won't get any additional cardioprotection by having that combo. And that data is pretty clear. Warfarin's been compared to aspirin. Warfarin and aspirin have been compared to aspirin alone and warfarin alone. Warfarin is cardioprotective. Now, of course, we use aspirin in general because it's much easier. But once you need the warfarin, your heart's protected, you're fine, stop the aspirin. And the only reasons you'd even think twice is someone who has a recent cardiac event or a new drug-eluting stent. That's a different issue. So now I'm going to go into the deprescribing thing, which is polypharmacy is defined as 5 or more meds. I don't know about you, but I'm told I have the highest number of meds on average in the seniors clinic. I'm still contesting that data. I'm aiming to be at 4 or less meds. That's what I was taught as a fellow. And 4 or less meds. It's hard to be at 4 or less meds. So interesting, I think Osler was the first geriatrician because he had the statement, so Osler, he lived from 1849 to 1919. So he's practicing around 1900. He's got about 3 drugs in his arsenal, sulfa, phenobarb, digitalis. And he's saying, don't take meds. It's what we should be telling people. Yet we have just the opposite, 100 years later. The masses are getting inundated with ads, and we're getting inundated with reasons from our evidence-based medicine to give our patients medicines, and they add up to problem. And so how are we doing with the polypharmacy world? So recent data says about 40% of elders are on 5 or more meds. So we're hitting the polypharmacy mark for 40% of our patients. We also have more than 10% who are taking 10 or more meds. And it just seems like unfathomable to take that many meds. There was a recent study in the geriatric literature that the UK has a big medical profile of their 100-year-olds. And they had 11,000 100-year-olds, and they looked how we doing with their meds. And 1/4 of them were doing pretty good, not taking any meds. But of the 3/4 taking meds, the average was 7 meds. Like if I make it to 100, I'm not taking 7 meds. I'm just telling you now, if any of you are prescribing for me. So I think we need to do better because the polypharmacy is a big deal. And it's hard to stop meds. I'm going to talk about that for the next few slides. But we know if you have patients on multiple meds, you're going to start having adverse drug events. And the likelihood of having a drug-drug interaction is 100% when you get to 8 meds. The likelihood of having patients mess things up, the cost of the meds, the drug-disease interactions because they're more vulnerable. So you and I might be able to handle a slight anticholinergic load. The older patient can't. You and I might be able to handle a slight sedating effect. The older patient can't. We get in trouble when we take a 80-year-old beaker that weighs 120 pounds and mix in 5 or more meds. And adherence, there is some data that adherence better if you have less pills. So the reason we aim at 5 is some literature like this, which is basically telling you there's an inflection point. And if you say, well, I'm on 2 or 3 meds, I'm doing okay here, but when I start getting to the 8+, I'm at about a 25% that I'm going to have some undesired effect. And the inflection point's around 5 or so. So I don't quarrel too much at the 4 or 5 range. When I get to 6 and 7, I start squirming and saying, how can I lower the med burden? So there's been a lot of literature out there, especially increasing the geriatric world, on deprescribing. So we're all taught to prescribe. We're all taught, here's a guideline, you have hypertension, you have diabetes, you have COPD, give drug A, B, C. And so I guess I will read it out loud, but it's a big process. It says, it's a systematic approach to identify and discontinue meds, and you have to think about the harms and are they outweighed by the potential benefits, and all of that within the context of the patient's goals, how long they're going to live, how well they're functioning, and their values and preferences. And it's hard to do that. And not only one by one drug, but you're supposed to look at the constellation of their med list and say they're on 8 meds. And there's 3 anticholinergic products here. We need to look at the cumulative risk as well. So there's all sorts of ways this has been trying to be approached. Some are just, I don't know about you, I get love letters from Express Scripts and Caremark saying, do you know your patient's on a Beers List med? For any students that know, the Beers List has been out there since Mark Beers at Harvard came up with a consensus panel saying here's drugs you shouldn't use in older adults because they have a high likelihood of causing trouble. They've become more evidence-based, and the last rendition's a couple of years old now, and they're pretty much on target. They are high-risk meds, but for the most part, we don't respond that well to a list saying, your patient's on a funny med. We usually got there for a reason. The Stop-Start is the European version, which is, I'd say, a tool to identify prescription problems in older adults. I'm going to just speak to a process which was first called the Good Palliative Geriatric Practice Algorithm, which was nothing more, I think, than a secret sauce of talking to patients and going through a process of saying, why are you on this med? Do you really need this med? Do you want to come off this med? And working with the patient's family and the patient's prescriber to make things happen. So these studies are actually relatively small, and they've been extrapolated, and I'll show you the new algorithm. But it was first done in nursing homes. They said, we know we have a lot of patients on too many meds. So they went and took 120 patients or so and said, let's look at your med list. The average was 7 meds. They cut them nearly by half. They cut out 3. What they found, and they had a matched control group for disease and other problems, only 10% who stopped a med came back on a med. But those who stopped meds in the stop med group, they had virtually, more than half of the rate of going to the hospital, and the mortality was lower. It's kind of like our hospice experience. You stop the meds and the patient does better. These patients did better in the nursing home with less meds. They then said, this is a pretty good thing. Let's do it in the outpatient sector. And they went, relatively small study again, 80-plus-year-olds, average of 8 meds, cut them in half. And they followed them for a couple of years. Literally only 1 in 50 needed to go back on a med because symptoms acted up. And no one had an increase in morbidity and mortality because of their cutting down of their meds. So this is not to go through this, but this was what their original algorithm was, which was really, what's the evidence base for using this med in my patient? Did the study apply to my patient? Is my patient getting benefit? Is this fit with my patient's goals, quality of life versus extending their life? And by going through one by one saying, in my mind, it's just the person scratching their head saying, do I really want to still take that pill? They were able to stop about half the pills in the study. But I didn't like this algorithm that they had. There was actually an evidence-based medicine, so I can say it's an evidence-based approach. Out of Australia, there's a big group who's done a lot of work with this. And they put in 10 steps, which is pretty hard to do. I only want to point out a couple of the steps. First step is a brown paper bag, which we have our patients do at least once a year, if not more frequently, bringing in all their meds, supplements, everything they got in a brown paper bag. And it's amazing what you find. There have been studies on this. 30% of the time you'll have meds that shouldn't be there or that you didn't know were there. The most secretive med that gets discovered is actually benzos. And there's other providers and people you didn't know about. So we always start there. And the other thing, just so I can say it's evidence-based, high-risk patients, over age 75, on 8 or more meds, and taking any of the Beers list or stop med list. There's HEDIS has a similar list. They say if you have those things, you should aim for less than or equal to 5 drugs. So it's not just me, it's the literature. And then they say, well, what do you do then? They first start with, and we'll go through this, how long is your patient going to live? Are they really going to benefit from staying on that statin, that bisphosphonate? What's their life expectancy and what's their goals? And then you start going through one by one. And again, I'm not going to walk through this. There's a 5-point version that I'll come to in a moment that basically says, what are you getting out of this pill? How's your life better? How's your quality of life? And what do you want to do? And most of the time, you can discontinue a fair share of meds. So I look to say, why aren't we all doing this? I saw a patient in clinic yesterday who was on a lot of pills. And frankly, I've been giving the talks, so I've been reading about it. And he's on a couple things that we stopped that I just hadn't thought about. He's been taking nortriptyline for forever because it's the only thing that helped him sleep. And he came in with dry mouth. And I'm like, geez, why am I still having him on nortriptyline? He last complained about sleep 5 years ago. This author who did this JAMA review and got it boiled down to 5 steps basically said drugs should come with an expiration date where they make us say, do you really still need whatever drug it is? Now, I look at it and say, their conclusions were, if you start a med, you have more likelihood to cause trouble than if you stop a med. So why are we so nervous? But we are. We don't seem to hesitate to start a med, and we're worried about stopping. And the literature's out there. When you stop a med, assuming you do it gradually, if it's a receptor interacting drug, the worst you're going to do is have some return of symptoms that you can resume the med. And a properly coached patient isn't going to get in trouble, not nearly as much as when you start the new drug, which we tend to do. So I think we hesitate too much to stop and too little when we prescribe. And a couple last comments on the evidence base. We have disease-specific guidelines that tell us, I have a diabetic. They need to be on metformin. Their A1C should be in the 8% range. They should be on a lipid drug, and their hypertension guidelines, and et cetera. And we land up with our patients on polypharmacy just by following the guidelines. The problem is the guidelines don't fit our patients, at least not in the seniors clinic, and many of yours in the general medicine clinic, because none of these patients were ever in those trials. So when they did a trial on COPD or hypertension or diabetes, they usually don't have the oldest old, the frail old ain't getting out too often to get in these trials with multimorbidities and polypharmacy. So it's a little tough. We have these guidelines. I don't want to ignore them, but they're to inform us, not to tell us what to do. It's to inform clinical judgment, not replace it. And so I like that. Frankly, I have more fun practicing geriatrics than when I'm on, look at my colleagues in the ICU. You have algorithms. I, in some ways, get to say, this is fun. And as, was said many moons ago, damn it, I'm a doctor. I get to make decisions with my patients. That's the fun and the art of medicine, and not just kind of following a cookbook, which mostly doesn't apply to most of our patients anyways. So speaking of guidelines, I'm going to come back to a factoid question. The hypertension guidelines have been struggling with the new sprint data and how low do we go with our patients. I'm going to take a moment and just say something about, let's go to the case scenario or the question. For patients who have just run-of-the-mill blood pressure problems, they don't have diabetes or CKD, which would make us have more stringent control. The JNCA a couple years ago said, you know, you're older when you're over 60. And after 60, we're going to loosen up our threshold. We're going to let you be 150. And we're not going to aim at 140 anymore. Now, the rest of the world doesn't think that. And there's a lot of disagreement even within the JNCA guideline creators. So just curious for fun, what do you think the rest of the world thinks is old? Because the U.S., as I approach 60, it's really annoying that the U.S. thinks 60 is old. But the rest of the world picks a different age to say, relax your threshold. So the answer, it turns out, is 80. And if you look at these various guidelines, everyone pretty much across the board, once you hit 80, says, you know, we used to aim at 140, but now we'll lighten up and we'll go to 150. And this is the International Society of Hypertension, the Europeans, the Canadians, and these are all relatively recently updated. And they're still sticking with, you're old when you're 80. But in geriatrics, we hate chronologic age. I mean, I have 80-year-olds who are players and in great shape, and I have 65-year-olds who look like they're 95. So it's not really your chronologic age, it's your physiologic age. So how do we gauge someone's physiologic age? How do I decide, should I treat them like they're 80? Should I treat them like they're 70 or 90? And I would propose the best way to check someone's physiologic age is their functional status, and you don't have time to do a whole functional assessment. If you just knew one thing, and I'm actually on a committee trying to get a national move to get the fifth vital sign, being your gait speed. And this would be the easiest thing in the world to do. You have someone walk 10 to 20 feet at their normal gait. And if they're at a clip of about, it's a little less than 2 miles an hour, the cut point's 0.8 meters per second, they're a player. They're a fast walker. They're robust. I don't care if they're 81. They're as good as if they're 71. I'm not going to count their age against them. And if they're a slow walker, we'll go through it. It kind of impacts the way that you might approach their hypertension. And there's some data to suggest we should keep their robustness in mind when we pick our blood pressure thresholds. If you're unable to walk, poor function, there's pretty clear data that those folks don't benefit from blood pressure reduction unless they've already had a stroke or heart attack. So if you are in a wheelchair and come to me in the clinic and your BP is 160, I should say you're doing fine. 160 is just fine, because treating them seems to increase their disability, not decrease it. So what's the data that's out there? There was a really nice review of the epidemiology of hypertension, and it kind of tried to put together the randomized controlled trials that we have with blood pressure thresholds. And what they found, it was all a modeling, but it was based on all of the randomized data, is if you've had a heart attack, if this is a secondary prevention, you've had a stroke or heart attack, we should probably aim at 140. The JNC, the other guys, you will probably benefit. I really can talk through, but feel free to. Thanks. So, bottom line is that's secondary prevention. If you're looking at primary prevention, if you're a fast walker, you will be in the category that I probably should aim at 140, and we'll get to the sprint in the next slide. If you're in the in-between, you're not wheelchair bound, but you're not walking very fast, those patients, the data is unclear, and depends on how aggressive you and the patient want to be. And back to the poor functioning folks, I'm probably only going to make them worse. Again, if they've had a heart attack or stroke, you could argue I'm still going to aim at the 140. So how do I fit this all with the sprint data? Because now we're told, should we aim at 120? So I think we all know, for anyone who doesn't know, students in the audience, the sprint trial was a large trial aiming at 120, and they had 2,500 plus patients with an average age of 80 in the older group. And they all benefited. Now, these were high-risk patients judged either by their cardiovascular risk, their age over 75, or having kidney disease, which we all know are risk factors. They didn't get to 120. They got to the low 120s, though, by adding pretty much one med on average to every patient's regimen. And even the older patients and even the frailer patients seemed to benefit. So then the issue became, well, so do I extrapolate this to my, nope, that was the wrong one. to my patients. So I'm going to give you a couple take-homes and a couple caveats. My take-home is if you're over 80, I'm starting at 150. I'll stick with the guidelines. But if you're in good shape or you've had an event, I'm probably going to go to 140 if you can handle it. And again, if it's going to fit within your preferences, your expected life survival. But if this is primary prevention, you're in. And by the way, 80% of your 80-year-olds and 90% of your 90-year-olds will develop hypertension. It's that common. You will be faced with high blood pressure. And I'm not looking to lower them beyond 140 across the board. Now, if they fit the Sprint profile, I think you can start saying, well, they might benefit from getting down to 120. Again, if they're poor function, I'm not going anywhere with it. But my Sprint caveats. The Sprint really was a somewhat unique group. They didn't have any diabetics because we weren't sure about what to do with diabetes. They didn't have anyone who had a stroke or anyone who had heart failure or anyone who had orthostasis. So this ruled out about half my clinic population. They weren't living in nursing homes or in assisted living. They were in the community, expected to do pretty well. So if you have a person who fits that profile, I think you could say, okay, I'm going for 120. I still argue to go to 130 first, make sure they're doing okay, handling the pill burden, then go to 120 if you can get there. Even in Sprint, the average patient needed 3 pills. They didn't get there in most of the patients. The other thing is you better not do it based on your blood pressures in clinic. We know older adults have more white coat hypertension. They come in, they have higher readings in clinic than at home. Very common. The best thing to do is do it by ambulatory blood pressure monitoring, though most people just get readings at home. In the Sprint trial, they checked your BP 3 times after sitting quietly listening to Mozart. They checked your blood pressure and averaged 3 readings. If you base it treating on what you see in clinic, you're probably going to get a lot of orthostasis and side effects when they go home and have lower pressures. And there is really a J-point curve. If your diastolic BP is below 60, that's probably a problem, increasing cardiovascular risk events of ischemic heart disease, and you want to avoid that. So my take-home is, again, some patients, if they want to be aggressive, I can be aggressive, but I'm not overly pushing it because I know I'm going to be at 3 meds in my polypharmacy tally up to 3 just with my hypertension if I go the route of the Sprint study. But the results are impressive if your patient's able to do it. Okay. So I have a couple of different topics for what do you do when you're getting older and frailer, and the last is going to be cognitively impaired. Are there changes we should make and revisit? So one is going to be cancer screening, and this was prompted by one of my patients 2 weeks ago in clinic, who is a very robust 87-year-old, despite her problems, which are diabetes, hypertension, hyperlipidemia, for which you can see she's on the usual meds, and she's on 3 meds. She knows about everything. She knows about the Sprint, and we're on 3 meds controlling the heck out of her blood pressure. And she said, gee, should I go in for my mammogram? I got my annual reminder from the radiology folks, which, by the way, they still send annual reminders, even though everyone said biennial. Every 2 years is completely appropriate in older women. But they shouldn't be getting it every year, but the radiology folks keep sending it every year. Every society agrees if you're an average risk patient, every 2 years is just fine for mammogram screening. So we went through and said, gee, you're functioning great. She works out. She's flying way faster than 2 miles an hour. And so the question is, what should I do with her? So I'll show you what we did with her, but you get to vote for a moment. Would the evidence that's out there say, well, yeah, probably should continue screening? Are the benefits of screening more likely to outweigh harms? Or conversely, is benefit unlikely and we have a high risk of harming her if we just screen? By the way, what does the general internal medicine world choose to say in their Choosing Wisely campaign? Because it's one of the things they voted on a couple years ago about what we should do with cancer screening in older adults. Okay, so it does turn out her odds of benefiting are probably remote, and her odds of having harm are probably substantial. The quick on the USPSTF, our guidelines that are evidence-based, they looked at this last year and said, we never did studies after age 74, so everyone knows we don't have data for age 75 plus. You're extrapolating, do what you want. We have no evidence, it's insufficient. So we're on our own from the USPSTF. At the bottom, I just point out the SGIM said, don't screen, just don't do it if you have life expectancy less than 10 years. And the American Cancer Society, who's usually conservative, said the same thing 2 years ago. I'll come back to the AGS in a second, but let's go through what the benefit and harm would look like. First off, I have to say, is she going to live long enough to benefit? You're supposed to live 10 years, so she's going to live 10 years at 87. These are just the standard life tables, and most women, when they get over 80, have about 10 years left. For the women, for men, it's between 75 and 80 for a man to have about 10 years of life left. Our patient seems to be, on average, not likely to live 10 years. But we all know this is kind of a mix of patients. And if you look and say, well, our patient could be on the robust side, and this is not even the 99th, this is the 75th percentile. So our patients around here, she might live 10 years to benefit. So I couldn't tell her this is just wrong, and the society says don't do it. Well, the Geriatric Society says once you've considered life expectancy, then look at the benefit and the harm. So this was from work done by Schomburg at Harvard. She's been doing this for years. Her last really good review was in JAMA, but she had a recap of it in our literature just about 6 months ago. And what she pointed out was, if I assume that what benefits there are at a younger age, which is reducing breast cancer death by about 20%, really still holds at age 75 and 85, here's what would happen if you screened a woman between age 70 to 79 every 2 years. You will basically get two saves. Two people who would have gotten breast cancer that they would have died of. Number needed to screen, 500. If they don't live out the 10 years, you didn't help them, and you could have hurt them, because for those who get screened for those every 2 years for 10 years, you'll get 200 false positive mammograms, which will lead to often just another spot mammogram or an ultrasound, but 10 to 20% go on to biopsy. And then you get about 20 cases of cancer, of which at least 30% are going to be false alarms that never would have showed up. It's the prostate cancer equivalent. Indolent never would have caused a problem, yet once they get diagnosed, they're going to end up with a lumpectomy or radiation or anti-estrogen therapy with potential harm all along the way, not to mention all the angst and everything else that comes with that. So the number needed to harm is 166. It's 3 times the rate of the number needed to screen. But you could argue I saved a life here. I only caused some overdiagnosis. But I'm looking at overdiagnosis, overtreatment. These aren't minor things, to be on an aromatase inhibitor for 5 years, and then you fall and break your hip from your problems that occur there. So to close up with our patient and my last topic, Schomburg's done a lot of work with the UCSF folks, have come up with e-prognosis, and I put it in the clinic, and I'll show you what came up for her. On the survival curve for her, it said she was a little less likely to make it 10 years, but 40% chance she'd make the 10 years. So reasonable to consider screening her. And then ePrognosis has put in her information for breast and colon cancer screening, and this is what came out. And so I showed this on the screen with her. And it gives you a barometer. You're really likely to benefit, you're really likely to be harmed, and this was her barometer closer to the harm side. And it says, it's not clear that getting screened will help you. And then they do leave it back, though. The person's thoughts and feelings should be the major driver. So of 1,000 people like her, I told her I think there's an overcall, but this is what the machine kicked out. 100 will have harm. I think mostly they're including anxiety from getting a mammogram or a follow-up false positive. Not many are going to go on to biopsy in that first year of screening. But the number needed to treat in a patient like this is 1,000. Number needed to screen to save one. So I showed my patient this, and she said, I'm doing pretty good. My mom and dad lived to the late 90s. I'm doing one more. So she's calling it quits at age 90. That's her plan. And if I look at this and say, just so you know, we've drinking the screening Kool-Aid in this country. So there's a lot of colonoscopy and a lot of mammography and even PSAs going on that are crazy. This was just a recent review looking at our screening rates in women. And the interesting, I don't think I did that. I'm leaving that to the tech folks to help out there. The half of the women with less than 10 years are still getting screened. A third of the women with less than 5 years are still getting screened. They're unlikely to benefit, and they're likely to get harmed. So I think in Schomburg's review, she said, you should probably have a conversation with folks, not when they're 90. Say, good news is you're 90. The bad news is you probably won't make it past 95, so let's stop all your cancer screening. That's not the conversation. The conversation is somewhere in their 80s saying, it doesn't make that much sense to keep doing cancer screening for forever. We'll think about it over time. You can start bringing in some of these tools, which are really easier and easier to access. And I think that's where we're going with that. So I'm going to close with end-stage dementia, something I saw 2 or 3 times last month on the ACE service. Just aside, Alzheimer's disease is going up as a cause of death. It's now number 6 in the United States. Coronary artery disease, still number 1, heart disease. It's going down. So since the year 2000, the rates of Alzheimer's disease death has doubled. The rates of cardiac disease has gone down. And I guess it makes me, philosophically, we're helping you not die with our statins and hypertension treatments of cardiac disease, but all curves merge. You are going to die, and I'm trading out some of my cardiac deaths for cognitive impairment because you made it to 90 and that amyloid kept building up, and now you have dementia. So the question is, Alzheimer's, for the most part, doesn't kill you. What do you think is the most common way that a patient, particularly with advanced Alzheimer's, dies? So there's your last vote du jour. Okay, great. And it is, and it's far and away pneumonia. And the issue is, what are we doing with these patients? So 2 out of 3 patients on their death certificate says pneumonia was the cause of death. And the question is, well, what are we doing? We know it's predictable. I have a patient with advanced Alzheimer's disease. They're in a nursing home, the vast majority of them with advanced disease, meaning they're not walking, they're not talking, they're not recognizing loved ones, they're in bad way, and they're in a nursing facility. We know they're going to get pneumonia 2 out of 3 times to take them out. And what do? And what we do is we tend to intervene with antibiotics. And what does that get for us? This is a bit of a unique study, but it shows a couple points I want to make. This was a VA patient population, so they're only men, and they're pretty sick, and they're in their age 80, low 80s. And they followed 100 men with advanced dementia, again, with that high level of impairment I mentioned. Over 100 of them got pneumonia. They weren't all in the same patient. Some had multiple episodes. And the mortality was extremely high. But if you gave antibiotics, and most of them, 77%, got an antibiotic, the 10-day mortality was halved. But all the curves came back together because it's just a marker. When you have a patient with advanced dementia getting pneumonia, it's because they have atelectasis because they're not moving. It's because they can't handle their secretions. It's because they are aspirating their food. They're going to get pneumonia again, or something else that's going to cause the end of their life. So you can intervene, and you can make a difference. And we had 3 patients on the ACE service last month with advanced dementia who came in, and, you come from the nursing home, you get PIP, Tazo, Vanco, you get the big guns. And the authors concluded, and I thought it was, really thoughtful, saying, we're not prolonging life as much as we're delaying or prolonging death. And we need to kind of address this. This was their curves, which are just, this is if you get antibiotics or you don't in the first 2 weeks, you're much more likely to live. But when you follow them out 6 to 12 months, most of these patients haven't made it. But these are unique patients, so I'm going to close with just this last group of patients. That group was all in Massachusetts. So is this. Boston has active Harvard nursing home studies with 20-plus nursing homes, which these are going to be typical nursing home patients, a lot more women, 80% women, 80-plus years old. Looked at them with advanced dementia, and what are we doing when they get pneumonia? Well, first off, they get pneumonia a lot. 90% of the time they get an antibiotic, though we usually aren't rushing them to the hospital. 20% of these folks went to the hospital. Most stayed at the nursing home and got an oral agent, and they usually got a quinolone. Their mortality was better if they got the antibiotic for the first few months. But the mortality begins to catch up because, again, it's a marker of advanced disease. These patients are going to probably expire in the next year. And NEJM looked at this half a dozen years ago and said, let's look at what happened retrospectively after they died. In the last 3 months, did they have burdensome things? And a fair chunk of them had IVs, went back and forth to the hospital or the emergency room. Some got 2 feeds because they couldn't eat. No one thought that the antibiotics improved their comfort. So I think the conclusion from this group of authors, and it's Susan Mitchell, led from Harvard, says, we're not so sure what we gain from the hospitalization. We're probably going to cause trouble between putting in IVs. We draw blood because we do in the hospital. They get delirium. They get the C. diff or the diarrhea. It's a problem having these patients come back and forth. But she argued in her 2014 study that part of this should be antimicrobial stewardship. We're giving these patients quinolones in the nursing home. We're giving them big guns in the hospital. They're going back and forth, and the multi-drug resistant organisms are growing. And this population, in their study, Mitchell's study, she showed not only did they get 1 course of antibiotics because they were prone to get infections, the average patient got 4 courses of antibiotics in their last year of life. And when they looked at those who got antibiotics, half of them developed new multi-drug resistance, and well over half of them had it at the end of the study. So it's a big deal. And I think I'm still looking and saying, when we get these patients, it's all driven. It's the U.S. You get to kind of demand what you want. But talking about it does matter, which is why I wanted to cover it today. And it really needs to be talked about in the nursing home, but ideally before the nursing home and in the clinics. And when you have a patient with dementia, it used to be on the most form, do I want antibiotics or not? And they took it off, and it's not something that gets prompted readily. But the NEJM review looked and said, the proxies who knew about the poor prognosis, that their loved one's probably not going to live more than the next 6 to 12 months, no matter what we do. But they're going to get complications. They're going to go back and forth. By the way, there's a public health issue for our antimicrobial problems. they actually they had a 90% risk reduction of having some of those interventions in the last months of their life if they were just well informed. So I think it's our job to be well informed. And frankly, at most of the nursing homes, you still get not that many patients who have do not hospitalize. There was a national study published in this journal here. It was a nursing home journal. Only 7% of Americans with advanced dementia had do not hospitalize. So they're still coming in. And again, we don't tell them not to, but I think we need to at least have the discussion long before they hit the ACE service. So I think I'm closing there and invite any rebuttals or discussion. So thanks for your attention.
Jeff, that was great. Is that your patient, by the way? There must be questions. Do we have questions from the health staff?
This is Dr. Schwartz's mother. Really doing great.
I don't think so. Yeah.
Well, it's being broadcast to the other side, so can't talk that loud.
Okay, so you mentioned like having a discussion for the patient's family members, if for patients with advanced dementia. At what point are you having that conversation? Is it when they're admitted with IV antibiotics, or when they have like in clinic dementia type patient?
Yeah. So in terms of when to have the discussion, I actually have to tell you, when we get a newly diagnosed patient with dementia in the seniors clinic, I think most of us are trying to have the discussion that the patient actually can be involved in. That I would say you're 75, you have dementia, you need to start thinking about what's going to happen if you survive the next 5 to 10 years. What would be an acceptable quality of life? And I'm not necessarily saying antibiotic or not when you don't recognize anyone and painting this picture, but I say if you got to the point, what's acceptable to you? And some patients say, I'm happy if I don't know what's going on. I'm in the nursing home eating ice cream every day. I'm good with that, and I respect that. But if the answer is, yeah, I wouldn't want to live and I wouldn't want to keep going on if I couldn't recognize my loved ones, or I was incontinent of bowel and bladder, I was pretty much bedbound. Those are the kind of things I then tease out. Once I have that, then it's kind of a take home from there is going to be okay. Then, we would let nature take its course if and when you had a life-threatening illness. So ideally, it happens way back when in the primary care doc's office. You're right. It's very hard. By the time they got to the hospital, someone's already decided. And we see the tip of the iceberg. We see those families who, most patients aren't coming in from the nursing homes, but when we see them, it strikes me, we're probably doing the wrong thing by patient suffering and by public health issue. So it's a process, and most patients don't come to it right away anyway. So I think that's why I like when the primary care docs at the seniors clinic start broaching these things, because half the time it takes months, years, 1 or 2 hospitalizations before they say, you know what, this is silly. We're not going to do that again. So I don't count it against them when they decide they still want those things, but long process of discussion. So the question pertains to exercise in older adults and what's the recommendation. And hands down, I debated about trying to fit it in. Even as fast as I talk, didn't have time. But exercise is hands down the best thing you can tell your older patient to do, and say, well, what should they do? The data is very clear. And frankly, my biggest motivator is their memory. So patients worry about their memory getting worse. And we have randomized controlled trials. If you walk most days of the week, and the big one that was in JAMA a few years ago was walking 30 minutes, 5 days a week. And people with memory problems did better, probably better than if you gave them donepezil, but they weren't compared head to head. So the goal for walking and aerobic activity is 30 minutes, 5 days a week. And it turns out you don't have to walk 30 minutes. The smallest increment that's physiologically beneficial is 10 minutes. So 2 10-minute walks is as good as a 20-minute walk. And if my patients say I can't even walk 10 minutes, I'm like, fine, you'll start with 5. But we got to aim at 10. 10's the minimum increment. And if you walk at the mall or out of the car and you go 10 minutes twice a day, you're 2/3 of the way there. I'm still an advocate of handing out pedometers and saying find your baseline and try and increase that by 10% or 20%. That's the walking side of thing. And that's everything. We know all the cardiovascular benefits, diabetes, hypertension, but cognition's the seller. My mom doesn't care if her blood pressure is 5 points higher, but she cares if her memory's better. So I'm shameless and say, you got to walk. As long as you can find your way back home, keep walking. The second thing is resistance training, and that's really increased. And that literature is also robust. If you work out, and the good news is you only work twice a week. Resistance training, that's the minimum increment to get benefit. So resistant training, and that we're talking, and there's great websites from the NIA that go and tell your patients do 10 exercises with 5 and 10 pound weights on your arms and your legs. And if you do that twice a week, 2 days a week, not Jack LaLanne, but 2 days a week, your hippocampus is bigger, your cognition does better. More importantly, I think, well, not equally importantly, is your function's better. So your muscle strength's better. You can get out of the wheelchair. You can get out of the regular chair, get out of bed. So function is all about keeping up muscle mass. So walking alone really isn't cutting it. We should be telling people, you got to get a little weight work and a little resistance training, even if you're starting with bands or 5 and 10 pound weights. And there's really great websites. We've been trying to work with the physical therapists to say, you got to push these patients. I mean, the fact that you're 90, you want to be frail, you want to be more robust, you got to get out there and lift some weights. So I have all my patients do push-ups in clinic.
Jeff, I wanted to also mention that sedentary behavior is also a problem. And so even people who can't get to 10 or 20 or 30 minutes, not being sedentary may have its benefits in and of itself. I wanted to go back to the SPRINT trial. So we've looked at data in about 2,900 patients in the seniors clinic, and the average age is about 84. And 90% of them will be hypertensive, 80 to 90% of them. And the average last sum of 3 blood pressures was 134. So the whole idea that it's very difficult or impossible to get toward those SPRINT trial numbers in older people is probably false. You have to do it carefully. You have to select your medicines carefully. But apparently we're doing that in the seniors clinic. I was stunned when I saw those numbers. So it's not something that is unattainable. You just have to be careful in how you do it.
And I think the main caveat I have there, though, is I'm very leery of my patients who are impaired. Obviously, if they're cognitively impaired or functionally impaired, I'm leery of how many pills I'm going to give them. But you're right. For the average person out there in the community, it's at least a consideration. But I think it's a discussion still, because some of my patients just don't want the extra pill. Dr. Albert?
Jeff, is there any new information on trials in animals or adults of agents designed to slow the aging process, antioxidants, things like that?
So interesting. I just have on my desk the exercise pill.
That's a personal question.
Yeah. We keep trying to find shortcuts. So it's like, so instead of exercising, since we know that stimulates certain, suppresses some cytokines and helps others, the study I was looking at is trying to replace the effects that one gets from exercising. So that's in the works in animals. I haven't seen any positive results. I mean, every time we do an animal study, the resveratrol was an example, in the red wine. Don't drink the red wine, get the magic ingredient and take that. And it looked pretty darn good in animals, and it doesn't look like it does anything in humans. All the human things, we've gone through the hormones and growth hormone. So I haven't seen anything new out there, and the latest thing is trying to replace the neurotropic effect and others that exercise does, but do it in a pill. So the exercise pill is underway, but until it's available, but it's back to Dr. Schwartz's point, you got to not be sedentary. So I'm not convinced that you're going to still do well with the exercise pill. You got to keep moving. Bob, you have one final comment?
There's a large study that is just started called the Molecular Transducers for Physical Activity Consortium. It's a $180 million study. One of the sites is here, and when the report is going to be running that is directly the entire study. And it's looking at the molecular transducers for physical activity across the lifespan. Children, young adults, middle-aged people, and older adults. So we may learn some of what is important to tease out in the effects of exercise through this molecular pathway.
My advice is time yourself, stay above 2 miles per hour in your average gait speed, and you'll be just fine. Oh, thanks for bringing up the exercise. One of those usual things. What do I really